issues that the NHS certainly faces in terms of challenge, but actually I think one of the issues that internationally is one of the biggest challenge for healthcare services, which is staffing capacity, staffing shortages. And what we want to do is focus on a part of the workforce that perhaps doesn't get talked about quite as much as they should do. In fact, I've been described by a national review as being invisible, and that's the healthcare support workforce. So that's going to be the focus of our conversation today. My name is Richard Griffin. I am Professor of Healthcare Management at King's College London. I've been working around this agenda in various guises for at least 30 years, actually, but very much focused in terms of my research and policy and operational work in the last 15 years on this workforce. Claire, do you actually want to just introduce yourself just briefly now, and then I'll move into what I want to say about the workforce.
Thanks, Richard, and good afternoon, everyone, and thanks very much for inviting me. So my name's Claire Fordham. I'm a physiotherapist, and I'm currently working in the North West London Integrated Care System as an AHP Workforce Transformation Lead. And as I head into my presentation after Richard's, I'll share a little bit more about me and some of the work that I'm doing in North West London and some of the work that I've previously been doing around physiotherapy support workers. And my presentation today is very much going to lead on from Richard's, and I'm going to be sharing with you some personal observations, insights, and then actually sort of move on to some really kind of practical top tips of what we can be doing in the here and now around supporting education training, career progression for this really valuable healthcare support worker workforce.
Brilliant. So I'm going to share my screen now, and as Jo said, there will be chance for people to ask any questions that you might have, so either in the chat function or we'll invite you to contribute later. We've had a few issues that people raised on social media they would like to raise as well, so we've got a couple of topics that we will talk about, but there's an opportunity to give us your views, feedback, any queries or questions. So just to kind of orientate ourselves a little bit about this workforce, I think there's lots of ways that it can be described, and I've put there in the title some of the ways that it has collectively been described. Some of those perhaps less positive than others. That unqualified workforce was actually a headline in the Telegraph from 2021, which described the unregistered workforce as unqualified, which it certainly isn't. But it's also known by its pay bands, which is always seems to me a very strange way to kind of describe any workforce, but also as unregulated, unregistered. So there's lots of different ways that this workforce is described, and quite often that's actually perhaps the description is very much about sort of deficit, if you see what I mean. That actually it's a workforce that lacks regulation and that it isn't registered, that is supporting. It's one of my views that actually we need to rethink this. Actually, we need to think about how we describe this workforce, much more in terms of what it actually does. And if we think about its characteristics, I mean, it represents, we're talking about the clinical workforce here, support workforce, it represents around a third of the clinical workforce, sometimes a larger proportion, sometimes less. Most often the workforce are recruited locally, live locally. My colleague at King's, Professor Ian Kessler, did some research that showed it's not untypical for support workers to actually go to school, to have gone to school very near to where they actually work. So it's very much a local workforce, which I think has lots of positive implications. Quite often come with previous employment experience, more likely to work part-time and have care responsibilities, work across all settings in the NHS, so not just hospitals, in primary care and community services. And quite often are the key in terms of frequency of contact, patient contact. So if you're in a hospital, it's quite likely that a health worker you spend most time, as I discovered myself only a couple of weeks ago when I had to go to Whipps Cross, actually it's support workers that you're most likely to meet and discuss and talk about what's going on when you're in settings. And the very aspirant workforce, they want to progress, they want to do as well as they can do, they want to acquire education and develop their careers. They're very loyal. Turnover rates on whole amongst support workers are lower than for registered staff, and they're very motivated as well. And they matter for a number of reasons, I think. I'm going to talk a bit about why I think actually that they have perhaps not received the attention that they could do in a moment. But there are a significant workforce. There's 375,000 support workers employed in the NHS. We know if we get their education and development right, that it can have a very positive impact on patient care. So, for example, there is research evidence around reductions in falls, around continuity of care, around infection control, around patient flow. So there is an emerging, it's still not substantial, and we need much more research in this area, which is one of the things I think the unit is doing a great job at King's, actually, is shining a light on the impact of support workers. But we do know that actually investing in this workforce does deliver benefits to patients, to service users, and also delivers benefits to organisations. So we know if we get this right, this is a motivated workforce that is engaged, to say lower turnover rates, low absence rates as well. So there's good reasons for organisations to invest in this workforce. And doing that also can have a benefit on for registered staff, so registered nurses, midwives, physiotherapists. There's some research in Australia at the moment that shows around 11 to 24% of clinical and non-clinical tasks that registered staff, like nurses, like occupational therapists, like physiotherapists, like radiographers, are undertaking, could safely be delegated to support workers. So we know how busy everybody is in the NHS, but actually we don't always have the right people doing the right tasks. So there's a real opportunity here to boost productivity by investing in this workforce. As I said, they are local, which means actually recruiting support workers means that the NHS has the opportunity to engage more with the local labour and skill markets, which has lots of benefits, including ensuring you have a workforce that is representative of its local community. But also actually being able to contribute to local economic growth. The NHS in most areas, and particularly with social care, is the biggest employer. So actually, it can make a real difference to local economies by recruiting this workforce. So I think there's a number of reasons why this workforce matters. I just very briefly wanted to, I spent a chunk of COVID and lockdown writing a book about the workforce. And one of the things I did for that book was actually go back and look at how the role has emerged throughout its history. And I think it's fair to say there's probably been support workers for as long as there's been anybody doing healthcare. There's been someone there supporting them. But I think the role really begins probably in the Crimea War. Florence Nightingale does write about nursing auxiliaries supporting nurses, so there are certainly references going back to the 1850s. But actually, to be honest, there's very little evidence until about the 70s about this workforce. We know they're there and debates do crop up. And there are developments. So, for example, the old pay system in the NHS does recognise these roles. I will talk briefly about the Briggs Committee in a moment, but really there's very little known during this period about what the workforce did, who they were composed of, the tasks they performed. Where there seemed to be an attention of them, the drivers for that attention were two things. One was around debates, particularly in nursing, about actually closure of the profession. So actually, if we want to protect the title of nursing, we want to regulate nursing, who's in and who's out. And that created debates at certain periods around a registered workforce and an unregistered workforce. The other big driver during this period was staff shortages. So Claire's a physiotherapist by background. There's always been people supporting physiotherapists, but they largely had a non-clinical role until the late 60s, when there was a big shortage, which there still is, of physiotherapists. But that shortage then led to the development of support roles, providing more clinical support for qualified physiotherapists. And that's a story that's very familiar in other professions as well. So shortage of professional staffs led to a rise in the use of other staff to support them in clinical roles. So there's not a lot we know from that period, but I think we saw a beginning of a step change, what I'm describing as kind of an emergence period that started in the 80s. Was very much driven by a rising demand for healthcare, an ageing population, for example, more acuity, more demand, concerns around public finance, concern that we need to modernise and a number of developments. And I won't go through all of this, but significant things happened during this period. Project 2000 changed the ways that nurses were educated, students could be treated. within workplaces, and that led to development of healthcare assistants. We saw significantly development of assistant practitioners, Labour's policies around new roles led, for example, to the MSW roles. So lots were happening during this period, but actually very much were in silos. So none of these developments, in my opinion, were underpinned by a comprehensive strategy. Individual things happened, they were good, but actually they weren't joined up into an overarching strategy. And probably not noticed by many people during this period, Bob Fryer, who sadly passed away a couple of years ago, while working Department of Health, produced the first dedicated report about the unregistered workforce, which was called Learning for Change in Healthcare. And what's striking about that report is some of the things that he said very much echoed with a series of reports happened in the next stage. So you'll see these periods are getting shorter. So I think there was another pivot point around the Francis inquiry mid-staffs that led to real concern around safety and the need to really look at some of the issues around the whole workforce, but also support workers, which led to initially the Cavendish Review, the creation of Health Education in England, Talent for Care, which was the first strategy dedicated to support workers, which sadly wasn't mandatory, and development of care certificate. So there's a whole flow of activity during that period, which I think was very much driven initially by that concern around safety, but also I think a growing recognition of the value of support workers. What I'm suggesting we're probably moving into at the moment is actually a new stage, which I hope is a consolidation stage. And the focus, I think, has changed. There's been a lot of focus before around education, for example, which is really, really important. But I think what we're seeing now is actually a greater focus on professionalisation of this workforce, understanding its scope of practice, understanding the competencies it requires. We've seen a number of very significant developments in those areas, in maternity, around allied health professions, and great work in cancer care and mental health as well. So it's been a really kind of significant change in recent years, which we hope will continue, although there is no guarantee of that. So as I say, there's been an evolution. They've been driven by different things at different periods, but they all represent a kind of a growth in the way that the support workforce has been perceived and supported. In saying that, the thing that struck me most doing the research for the book was just how much the issues this workforce faces endure. So I mentioned earlier Briggs' report. This is a report into nursing published in 1972. It did touch on the unregistered workforce. It talked about issues such as access to education, inconsistent access to education. It called for standardisation of titles. It called for standardisation around job content. Shape of Caring was the last review undertaken in 2015, explicitly addressing healthcare assistants and nurse in this case as part of Lord Willis's wider review. Talked about the same issues. And the review of the research shows that actually there is across occupational groups. So whether allied health professions, whether nursing, whether branches of nursing, the same issues keep occurring. So issues around job design, scope of practice, titles, the amount of titles used to describe this workforce is quite staggering. That is an issue more generally in the NHS actually, but certainly for the support workforce, similar roles described in very different ways, which can be confusing for staff and it can be confusing for service users as well. Inconsistent grading, inconsistent entry requirements, and inconsistent access to education. And also truncated career pathways. So this, as I said earlier, is an aspirant workforce. They want to progress, they want to develop, but often don't have the pathways, the work-based pathways to do that. There's also a lack of data often about the workforce, which is another indication of perhaps how it's not been as valued as it could be, and it is under-researched. There's only one journal, the British Journal of Healthcare Assistants, that is dedicated to this workforce. So we have far more research on the registered workforce than the unregistered workforce. So what we know, although it's growing, we could certainly do with a wider knowledge base. And this, the consequence of this is sort of at the start. We know demand is rising on the NHS. We know before waiting lists are considerably rising. We know there are significant staff shortages. So what all those issues mean is we're not getting the optimum contribution of this significant workforce, which, as I said earlier, is often the main patient-facing member staff in many settings. So there's a real missed opportunity, I think, here for any government. And I should say, actually, those issues have endured, whether it's been a Labour government, a Conservative government, or coalition government. There is no difference politically in this. In fact, I'd argue, actually, we've made more strides in the last 5 to 10 years than any other period, actually. But what it means is we are not getting the best out of this very valuable resource. And support workers will often feel undervalued and frustrated. There was a piece of work done around mental health, nursing HCAs a couple of years ago, a report by the Nuffield Institute, which described this workforce as untapped. It's a resource we can actually get more from. And I was lucky to do a bit of research associated with that. I interviewed a support worker who described that they had a rewarding job but a frustrating career, which I think captured it really well. They loved the work that they did, but they wanted to do more and just couldn't actually maximise their potential. And just to unpack that a little bit more, there is an evidence base actually from the NHS about some of the consequences of this, but those points I've just listed there actually from a study that was published this month in the Harvard Business Review, which was actually looking at low-paid workers generally in areas like retail. So it wasn't actually about the NHS, but these issues all occur in the NHS because we're not investing sufficiently in this workforce. So we know retention is lower than it could be. We know there's higher absenteeism than it could be, more overtime, certainly a consequence in terms of the use of agency staff. If you've got higher turnover rates than necessary, then you have recruitment costs and onboarding costs. Morale is lower than it could be. You're losing institutional knowledge, and productivity isn't as good as it could be. So if you think back to that statistic, around 11 to 24% of tasks could be delegated. That represents quite a significant productivity gain. So there are real significant issues that result from the fact that the workforce has not been invested in as sufficiently as it could be. Investing in it is not the only answer, clearly, but it could go some way to dealing with some of the challenges the NHS faces in terms of performance. And what is quite interesting is in countries like Australia, where they are also dealing with the same sort of issues that we're dealing with in England, they are looking very much to this workforce and very much to investing in this workforce through grow your own strategies as a way to deal with some of these issues. So I suppose it kind of begs the question, why? Why is it that what Asa Briggs was writing about in 1972, what Camilla Cavendish in her review wrote about nearly 10 years ago in 2013, in July 2013, and research is still telling us, why do these issues endure? And one thing to say is this is not a wicked issue. It's not an impossible issue to solve, these issues, that's barriers that support workers face. Other industries do that. Do look at their workforce in a different way than NHS seems to, and does able to actually address some of these issues. But it is what I call a meta problem, which simply means it's a problem. We can't simply look at one issue that support workers face, for example, access to education, address that and think that everything will be solved. It will probably make things better, but it won't solve all the problems. If you haven't got good job design, if you're not sure about the competencies that you're meant to have, if you haven't got well-defined career pathways, then actually access to education is going to have a limited value. So, this is a complex problem. And I think, as we hopefully we'll hear from Claire later, there are opportunities around coming together and working as systems to deal with some of this stuff, but it's not impossible to solve. It's not a wicked issue. Clearly, it is part of a product of the history, so it is path dependent of decisions that were made in the past, or rather the lack of decisions, the lack of policy, even when things like the assistant practitioner post was first developed, the amount of national guidance was incredibly minimal. It was really quite shocking, actually, looking back to how little advice was actually provided around some of these really critical roles. So that lack of nationally mandated workforce policy means that it's been left to local employers to decide how to develop the staff, how to name them, how to grade them, what their scope of practice is, which has led to the inconsistencies and lack of standardisation. But I think that doesn't really answer it at a deeper level. I think actually, why is it this has been left to local employers to leave, and why it's not been the focus of national policymakers to the extent that it should be? I think The only conclusion, I'd love to do a bit more research on this, but the conclusion I've come to is actually the NHS is what's called, and I'm an economist by background, what's called a dual labour market. So there are two labour markets in the NHS, a primary one and a secondary one. And the primary one sits the registered workforce, and the secondary one sits the support workforce. And I won't list all of that, but you can see the differences that both those workforces characterise. So professional body membership, I think professional bodies have been fantastic, and I think they're key partners in the positives that have occurred. But professional body membership has actually been very recent historically. Historically speaking, support workers have joined trade unions, but they haven't been able to join professional bodies. That's been a relatively recent development. We know, and I think this is appalling actually, to be honest with you, but we know there's no CPD funding available to support workers, dedicated, protected CPD funding. There's access to the apprenticeship levy, but actually CPD funding, when it was made available to register staff, wasn't made available to support worker staff. So there's lots of differences which characterise different labour markets. So we're treating people in different ways in the NHS because they exist in one of these two labour markets. And one of the features of dual labour markets is it's very hard to move from one section to the other. And one enduring issue we do know that support workers have faced is exactly that. It's very hard to find a work-based route from that secondary market into the primary one, even though at least a quarter of support workers are much higher in some professions want to progress to be registered professionals, which, given the shortage we have of registered professionals, is another missed opportunity. So there seems to be something around this to me, that there is this difference in approach. And if we look at dual labour markets generally, they're not driven by the value of the worker. They're actually driven by other characteristics. So it may be classically that it's gender that is making a difference, or ethnicity. But actually, in terms of the NHS and the clinical workforce, that doesn't hold. Both are female-dominated workforces. Ethnically, they are very, very similar in terms of the composition. The third candidate for dual labour markets is socioeconomic factors, class. This is what I'm wondering whether it is one of the issues. It's something I argue in the book, that actually there's something about this workforce coming with different socioeconomic background. I said there were schools, not higher education. So, there may be something there that is actually driving it. But I think it's a really interesting question. Why have we had this situation where this part of the workforce is actually not received this sort of attention and investment that it should do? However, to be positive, because actually that timeline I showed earlier, I think we're at a really, really positive point. And I think there are lots of reasons to be cheerful if you are a support worker or you work with support workers. I think this focus on competency, on scope of practice is really, really critical. And I think the strategies that have been developed, particularly for allied health professionals, particularly in cancer services, or for support workers in cancer services, work that's being done individually by professional bodies and unions, is significant now, because what it is doing is bringing this together, is bringing all the elements together. It's no longer look at the elements in silos and saying, well, actually, we need to look at how we recruit people. We need to look at job design. We need to look at scope of practice. We need to look at actually the support that we give managers in areas like appraisal. So there's a lot of great work bringing this together. I won't, again, list all of these, but recent examples are the maternity one, the cancer one, the HP one. Good work in Scotland. We focused in this discussion on England, but actually NHS Education for Scotland has been doing really good work defining role levels of practice, competencies, education requirements. We're seeing celebration months now, or weeks, sorry, or days for support workers, which we weren't seeing 5 or 6 years ago. So actually individual occupations, mostly led by professional bodies and trade unions, celebrating explicitly the contribution of this workforce. I think 2 weeks ago, we saw the publication by NHS England of the Learning Roadmap. So there's lots of great occupationally based activity that's going on. So I think we have an opportunity now to actually not miss the contribution this workforce can make. And if there was ever a time that actually we did need to think about this workforce and how we can get the best out of it for patients, then now's the time to do it. So I'm going to pass over to Claire now and stop sharing my screen. So to you, Claire.
Thanks, Richard. Right, let's make sure I can share mine. Can everybody see that okay? Yeah, you're seeing my full slides. Someone's going to have to speak to me as I can't hear you. Can't see you.
Yeah,
You can see those. Okay.
It's still showing in preview.
Is it?
Format,
Right.
rather than
Okay.
slide format.
Let me try again.
That's perfect.
How's that?
Yeah, perfect.
Oh no, that's showing in preview again, isn't it? Anyway, in the interest of time, if that's not too distracting for everybody, I haven't worked on Zoom for so long. Is it all right if I just crack on? I hope that's not too distracting for everybody. So thank you very much, Richard. I want to start following on from Richard, just giving you a little bit more information about me and then what I'm going to be sharing in this next section. So I'm a physiotherapist, spent 28 years in clinical practice and therapies, leadership and management. And then 4.5 years ago, I moved to the Chartered Society of Physiotherapy in a role as a professional advisor for workforce and education. And along with colleagues in the strategy, policy and engagement directorate at the CSP, I had a specific remit to explore and develop the Society's position, support, resources and advocacy of the physiotherapy support workforce. And really importantly, actually, we set about doing this work hand in hand and in co-production with physiotherapy support workers who are members of the CSP. And I'll come on later to why that's really important. And I think the work we undertook and the work that the CSP continued to lead was actually really significant and influential for the whole of the allied health professions support workforce, and indeed led to the development of the AHP professional bodies coming together and developing a collaborative position statement on the value, role and the need to invest in AHP support workers in terms of their education, training and development. And I moved from the CSP quite recently now to work with the North West London Integrated Care System, with the AHP Council and AHP faculty. That's the allied health profession chiefs and leads and practice development leads across North West London last September as their workforce programme lead. And along with colleagues in the council and the faculty, I'm delivering a suite of influencing activity and projects seeking to address AHP workforce supply and retention challenges in our system. And we've got a very specific focus on implementing a grow your own workforce strategy, and with it influencing for investment in the support workforce. So I've been working in a variety of ways in this space for some time now. And what I'm going to share with you now is exactly what it says on the tin here, some personal insights and observations of the issues that play out in practice from what Rich has just described, the sort of policy gaps, the history around support workers, and you know, really how they play out in practice. And then I want to join Richard with reasons to be cheerful and actually share with you again some practical recommendations from what I've seen works and what I believe works about what should and could be happening now that could have an impact quite quickly as we all work together in this brave new world with policy shifting forwards in terms of getting things right, of how we value and support the learning and development and access to education for our support workforce. So no apologies for the fact that my insights and learning are from physiotherapy and more recently from all of the AHP professions, but I would put it to you, and I know that Richard will agree, that the insights and observations I share, the top tips and practical recommendations I'm going to give you are applicable across the board for all healthcare support workers. So I've observed 5 issues that I think play out in practice as a result of what Rich has just articulated, this sort of policy vacuum. And the first observation is that healthcare support worker role development has happened organically over the years in response to changing demand and to suit local needs, and absolutely not as a result of mandated policy around growth and development. And the second observation is because of that organic growth, at a practice level, there still persists this real confusion around scope of practice for the support workforce, and nervousness about scope of practice for the support workforce, and therefore the tasks, activities and responsibilities in each practice context for various professional groups that could or should or indeed should not be delegated. And we think we understand support worker scope of practice. If you ask practitioners and support workers, do you understand support worker scope of practice? Everybody says, oh, yes, I do. But actually, when you really dig into that, in my experience, registered practitioners and the support workforce are not terribly clear on the underpinning principles around scope of practice. And we see that borne out in this desire to seek a sort of recipe book type guidance of, what could and should somebody be doing? What is the list of task activities? And I used to get that question into me in the CSP all the time. And so there is still this confusion around scope of practice. My third observation, most recently, I suppose, is that despite the new strategies and all the reasons to be cheerful that Richard cites, and this encouraging renewed focus on the need for healthcare support workers to be supported to undertake occupationally relevant training and development, there remains, and it's because of the decades of inattention, really disparate and inequitable access to training, education and support for support workers. And Richard and I recently ran some workshops for the occupational therapy support workforce in Northwest London. And I think I'm right, Richard, aren't I? In that when we asked in that group, given the senior healthcare support worker level 3 apprenticeship in England has been around for a while, and there's a dedicated therapy pathway in there, when Richard and I asked the group, has anyone undertaken the level 3? Does anybody know about it? Has anybody had access to it? It was a sea of blank faces, Richard, wasn't it? So somehow, there is still this sort of disparate and inequitable access. And what really fascinates, and I suppose shocks me about this as well, is that this is a third of our clinical workforce we're talking about. And we know that there is a really clear link between staff experience through the training, development, supervision, support they are given. So we know that all of those things lead staff to have a good experience in the NHS. And we also know that good staff experience directly links to patient experience, patient safety, and patient outcomes. So if we give staff a good experience, generally speaking, our patients get a better outcome and our patients get a better experience. And yet a third of our clinical workforce, we're not giving a very good experience because we're not supporting their training, education and development in a way that we ought to. And my fourth observation, and this is a really uncomfortable truth, but it's important that we out it. My fourth observation is that some of the barriers to accessing learning and development for our support workforce are perpetuated by culturally entrenched attitudes to the support workforce from registered practitioners. You're just a support worker. You're an unqualified member of staff. And Richard alluded to class, didn't he? And Richard and I have had many conversations about this. And we think there is some real intersectionality going on here. And classism could well be part of it. Interesting observation. And my fifth observation, which kind of chimes with my second observation on the previous slide, is that actually, because of this renewed focus and energy, there's loads of information out there now, and there's some really great progress being made by national teams and professional bodies. But actually, it's really challenging for our workforce to translate all of that into practice and make the changes we need to happen in practice. And that's because it takes time, it takes courage, it takes dedicated and skilled support, and importantly, headspace to do all of this work. And all of that is really, really challenging to prioritise for our teams who are working under extreme operational pressure in the midst of a workforce crisis. But it's really important that we do this stuff. So there is something for me around, do we have the right supporting infrastructures in place in order, the whole workforce to have the support they need for learning, training, education and development. So that said, more positively, despite those issues I've just alluded to, I have also witnessed and heard at local team levels that support workers can feel highly valued by their patients and highly valued by the direct team they work alongside. They don't always feel valued by sometimes their trust and their health board, and certainly not by policymakers often, but they do feel highly valued by their patients and the staff they work alongside. But for me, there's this sort of really remarkable paradox here. So what we hear is that often practitioners will tell us they are so important, this workforce, that our services cannot run without them. And as a result, they are therefore then the least likely to be released for training, development and education. And you know, it's this remarkable, what I call the practice paradox. The role is considered so vital to service continuity that training and development is sacrificed as a consequence. And we need to be thinking really carefully about that paradox at a local level. But there are exceptions. Things are changing, and there are some islands of really outstanding practice out there. It's about how do we get the spread of that great practice. And I want to take an opportunity actually to shout out a team that I'm working with in Northwest London at the moment. So they are an adult community rehabilitation team in one of our boroughs in Ealing. And they are the Central and Northwest London NHS Foundation Trust. And this community rehab team I'm working with as part of a project we've got going on at the moment, supporting teams at a local level to look at whether the tasks, activities and responsibilities their rehab support workers are undertaking map into the HP competency framework. And I've been conducting some interviews with their support staff, and what they're sharing with me are really outstanding governance structures in their team, and really fantastic support for their learning and development and their access to learning and development. And they're a real sort of shining beacon of what good can and should look like, and they are making it work. And we'll be sharing that. Some of the work we're doing in Northwest London that we'll also share nationally, we'll be sharing some of those exemplars of good practice. So just moving on now to echo Richard's comments again on reasons to be cheerful. We absolutely are beginning to see a policy shift that should begin to address for the longer term some improvements to accessing learning, development and unlocking career progression opportunities for our support workforce. But what I'm going to suggest to you all on the call is don't wait for these policy directives to filter through and tell you what you can do. There are some immediate and impactful quick wins, things we can all do at a practice level. And I'm going to move on now to sort of share what I think some of those things are, and particularly what I'm going to share with you that I hope will be helpful, given that scope of practice is this question that comes up over and over again. How do we know what the scope of practice is? What does that look like? I'm going to share a pragmatic approach to understanding scope of support worker practice in a local context, which I've developed and I'm using with local teams, which in turn can be used along with applying the underlying principles of delegation in decisions about what tasks, activities and responsibilities could be safely delegated to support workers. So what works and what should we be doing? So the first one's really simple. Speak to support workers. Ask them, what do you need? What are your barriers? What's happening for you? How can we help? It's really simple. And it sounds so simple and so straightforward, but there are still services and teams out there that do all of this work in isolation and don't communicate with their support workforce. One of the things I learned at the CSP, and I was supported so brilliantly by our associate members of the CSP, is that it's absolutely critical that they're involved in some of the solutions. And a recent mapping exercise that all trusts in England have done with their HP support workforces recently around education levels of their support workforce has just shown at a local level that local leaders don't always know. They don't know they don't know what qualifications their support workers hold. And support workers hold everything, unfortunately, from no qualifications other than the care certificate because they haven't been given access. Some staff still don't have access to functional skills, even though they could get that qualification in practice now, right up to PhDs, but we don't know their education levels, and that's really important. So speak to your support workers, know who they are and know what their education and training levels are and what their aspirations are. Explore the local barriers to training and education hand in hand and in co-production with support workers. Again, traditionally, local developments around education, training and support are done unto our support workforce. And however long you've been in practice, you cannot understand the perspective of support workers and the lived experience of being a support worker unless you have been one. And I haven't been a support worker. So in my work in North West London, it's absolutely critical that I listen to our support workforce and listen to their lived experience and believe their lived experience. Don't assume just because you've been a registered practitioner for a long time and worked with many, many support workers that you understand their issues. You can't possibly unless you've had that lived experience. So for leaders out there, really critical that the support workforce is included in your workforce planning. And this has not traditionally happened. We have traditionally overlooked the training and development needs of the support workforce. We've overlooked the planning for training and development for a third of our clinical workforce. Think about the strategic commitment necessary at a local level to invest in the infrastructure and the capacity to level up access to training and development. We're seeing emergence of brilliant new roles around support worker education and development leads, and we really need those roles to support this levelling up around access to learning and development. It's sort of not necessary and not always helpful that this is all conducted by registered practitioners. Again, that lived experience makes a massive difference for everybody. Easier said than done, but it's absolutely vital. Address outdated job descriptions. And in those, make it really clear what the education and training requirements for roles are, or commit to supporting the essential education and training for somebody if they haven't already got it as they move into role. And we can do that. We can commit to these things. Really important that we empower the support workforce to understand the importance of undertaking occupationally relevant training and development, because it is one way that we can start to bring about standardisation and consistency in roles, and therefore greater confidence in support worker scope of practice delegation, empowering everybody to feel more valued and the support workforce to feel more valued in their role. But the support workforce themselves, they need time and support to understand why that's important, as well as the experience they've gained in practice. And here's the really critical bit. I spoke about the information that's now coming through, and I'm going to highlight some of the same resources that Richard did, some of the competency frameworks, some of the clinical speciality frameworks, really, really great pieces of work that help us to understand scope of practice. But you need to work with those resources and you need to operationalise scope of practice in local roles. And I'm going to share with you in a moment how you can go about doing this, really drawing on those professional and clinical capability frameworks. So many tools out there now. So here it is. So this is a tool that I've been using at a team level to support practitioners to understand support worker scope of practice in local contexts. And I call it the ladder of logic, and I hope it's helpful for you. So you work up from the bottom. And the first thing to do is ask yourself, are there any legal frameworks that stipulate what should not be delegated to the unregistered workforce, to the support workforce? That's your first step on the ladder. And actually, there are surprisingly very few legal frameworks that stipulate what can and cannot be delegated. Then you look to your regulator. So that's the Nursing and Midwifery Council, the Healthcare Professions Council, and look at what their guidance is. Have they got any stipulations in regulatory frameworks about what can and can't be delegated? And as you're starting to work out, you're starting to then pragmatically think, is this, can this be something that could be delegated? Is this something that could be in the scope of practice as support workforce? And then here's the bit that's been missing for a long while, and why we have got in such a pickle around scope of practice, because it's never really been articulated in a way that it is now being articulated. It is only probably a handful of years ago, Richard, I think, isn't it, that we first started seeing the support workforce in anyone's clinical capability and competency frameworks. They were only ever inclusive of the registered workforce. And so it's inevitable that people were thinking, well, what does that mean support workers can do? What's in scope of practice then in this local pathway for the support workforce? So the guidance we have now from professional bodies and clinical speciality and pathway groups really now clearly sets out expectations around roles and responsibilities, core competencies, and therefore the extents and limits of practice for the support workforce. They're relatively new, but they're really welcome, but you need to look at them and use them in practice. So that's your kind of third step on the ladder. And that really then helps you in a local context start to think about, what is height of scope of practice for our support workforce. And then two really critical things. You then have to think about your local considerations. Are there any limits to delegation or scope of practice as articulated in contracts of employment and employer policies around scope of practice? And unfortunately, they trump everything. But if you work up those first three rungs of the ladder and you find, what you're thinking about that you could safely delegate it is trumped by an employer policy, you've actually now got the tools to actually challenge that policy and think with colleagues, is this still relevant? Is this still necessary? Where has that local policy come from? Could we challenge that? Is it the right thing to do to challenge that? And then the most important part is the extent that an individual support worker is trained, educated and competent, and that they have supervision in place, good governance in place. So that's the difference actually between support workforce scope of practice and then the scope of practice of an individual support worker. So it's sort of simple, but also sort of complex, which is why I've kind of put it in the ladder of logic. And if you do this together in your teams, in your local practice context, you then will be able to quite confidently then move to make those professional judgments. Because again, just because something could be delegated doesn't always necessarily mean that it should, but that ladder of logic helps you identify what could be, what is in scope of practice, and then you make that, using your underpinning principles of delegation, you make that professional judgment about what could be delegated. So continuing with what works, what should we be doing? Really simple stuff. Commit to regular and relevant in-service training for your support workforce that is co-produced and co-delivered by support workers. Don't just plonk them in a room with all the registered staff and think that this is what they want. It starts right back at the beginning. Ask your support workforce what they want. What do they want their training and development to look like? What do they want their in-service development to look like? Great example, I'll give a shout out to CNWL again now. CNWL, this community rehab team, every Friday, they run a competency clinic. It's a drop-in clinic, and they cover all of the sort of basic core competencies for their support team, supported by registered practitioners and support staff, and staff can drop in and out whenever they want to. If they want to refresh on a competency, they need a bit of support from training and development. Yes, you need capacity to deliver that, but it pays back in spades because they have this really empowered, really competent, really confident clinical support workforce in their team. Brilliant, really outstanding practice. Make it really clear to support workers what training and development pathways are available. Make sure that's communicated, supporting people to be the best they can be in their role, pathways to move up as a support worker, if that's what people want to do, pathways to move into registered practice, if that's what they want to do, and pathways to move in a different direction in health and care, if that's what they want to do, because there are numerous ways our support workforce can develop. This is one that's I'm really passionate about. Support your healthcare support workers to engage with students, our pre-registration students on placement, and contribute to students' learning and development in the practice environment. Structured and planned, not as a just could you take the student for the day. Couple of links to some important information that will help you. And my final top tip, which is look into the pool of talent. And it is with absolute joy I share this photograph. This came from our Physiotherapy Annual Representatives Conference last June. And what I want to share with you is this collection of people here. And in this collection of people, there are leaders in the physiotherapy profession. There are educators in the physiotherapy profession. There are advocates and activists of the physiotherapy profession in this group of individuals. And apart from me on the right and a colleague from NHS England on the left, Gabby Ford, they are all support workers. Look into your pool of talent. The talent is there if you look. I will stop sharing there.
That's a fantastic